Hey everyone, and welcome to, let's call it Pearls of Wisdom. I think I'm going to go with that until I come up with a better name. Pearls of Wisdom for Thursday, August 25th, 2016. So quick one today. I want to talk quickly about a new tool that I've been developing for the past 6 or 7 years now, I guess, called the Multidimensional Symptom Index. Now, this will be the third of 3 tools that I've been developing over that time, and all of them came out of my interest in either prognosis or measuring outcomes and measuring recovery. So some of you will be familiar with the Satisfaction and Recovery Index. I actually just presented that tool at the IFOMT meeting in Glasgow a month or so ago. And the Traumatic Injuries Distress Scale is going to be published in the Journal of Orthopedic and Sports Physical Therapy in an upcoming special issue in the fall. Those two are pretty well done. We continue to work on them. We're going to translate them into different languages and that sort of thing. But the third one is called the Multidimensional Symptom Index. This grew out of a series of focus groups and work we did a few years ago, several years ago now actually, where we asked people who had chronic pain, mostly chronic neck pain, basically how the recovered version of them would differ from the current version of them. In other words, how will you know when you're recovered? Many of the things they said ended up in the Satisfaction and Recovery Index. Things about future potential, enjoying intimate relationships again, having the sort of ought physical and mental capacities they think they should have. But of course, a number of them talked about symptoms. But it wasn't just the intensity of their symptoms that they were concerned about. A lot of them talked about the manageability of their symptoms and the frequency of their symptoms. Anyway, I tell you that story so I can tell you this story. We took all that information they provided, we created a scale, and I'll share that scale with you in another post. But on that scale, that multidimensional symptom index, we can get 2 indices. We can get several, but 2 of the indices we can get are pain-related interference or intensity and pain or other symptom frequency. I decided to take a look at these in a cohort of people that we've been collecting just recently, in combination with a body diagram as well. So in other words, the location or the amount of the body that's in pain. Now, anyone who knows me, who's seen my MedBridge sessions or who's been on a course with me knows that I love me a good body diagram. Anyway, that's beside the point. I took those 3 parameters: symptom-related interference, symptom frequency, and the amount of body that the symptoms were in. And I put them into a regression analysis, a multiple regression analysis where the predicted variable, the dependent variable, was pain-related disability or interference, measured with the brief pain inventory, usually fairly well-recognized tool. What's interesting, so a regression will normally go through and say, okay, if we look at the relationship between variable 1 and the outcome, is that important? If it is, we'll keep it in. Then what if we add variable 2? Does it tell us anything above and beyond what variable 1 told us? If it does, then we keep that in. Then we add variable 3, and so on. Does it tell us anything above and beyond what variables 1 and 2 told us? In this case, all 3 variables were retained for describing or for predicting disability or interference scores. The point of that is this. Frequently as clinicians, we are pretty good at capturing pain-related intensity. We ask something on a 0 to 10 scale, how would you rate your pain right now, maybe over the past 48 hours, at its worst, at its best, that sort of thing. Rarely, in my experience at least, do we measure frequency of pain or other symptoms. And also, rarely, it sounds like, based on my experiences teaching clinicians, do people capture a body diagram to look at the extent of body in pain or other symptoms, numbness, tingling, that sort of thing. But it seems that those are very important. So the next time you're assessing your patient who's complaining of a pain-related problem and you're looking for an outcome to follow, don't just look at pain intensity. I know it's simple, but consider adding pain frequency at minimum. And that can be on the same 0 to 10 scale. Make it a percentage of the day, 0, 10, 20, 30, 40, 50, 60, 70, 80, 90, 100. And I'd strongly encourage you to consider a body diagram. There's one for free on the lab's website. There's a number of them out there available. There's a couple of really cool online interactive ones. Maybe in a future post I'll show you some of those as well. So there you go. That's my tidbit for today. All the best.